This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. Thank you for those of you who are here in person today to welcome our visiting speaker, Dr. Emily Lau, who is an assistant professor and director of cardiometabolic health and hormone clinic at the Corrigan Women's Heart Health Program at Mass General. Dr. Lau went to undergraduate at Brown University and went to medical school there, followed by internal medicine and cardiology training at the Brigham, where she was also chief resident in internal medicine. She also did a year of echocardiography fellowship at Harvard. Dr. Lau has had numerous awards under her belt, just starting as a junior investigator. And I'm not going to name all of them, but examples include Doug Zipes Young Scientist Award and Young Physician Scientist Award of the American Society of Clinical Investigation recently. Her research is funded through the AHA Career Development Award, as well as she's in her third year of the K23 award supported by NHLBI. Her research really focuses on sex differences in women's heart health with a focus on menopause transition as well as HFpEF and inflammation. We're really excited to have you here in person. She gave a wonderful talk before the pandemic for our sex-specific conference focused on HFpEF. And today she's going to focus on menopause and cardiovascular disease. And we're so glad that you're here in person, and I'll turn it over to you.
Well, thank you so much for that very kind introduction, Dr. Mehta, and just thrilled to see everyone here this morning and those online. And I think you'll be thrilled to know that we're going to be spending the next 45 minutes talking about the least glamorous topic imaginable. As American author Ursula Le Guin, she said it best, menopause is probably the least glamorous topic imaginable. A serious mention is usually met with uneasy silence, a sneering reference met with relieved sniggers, and both the silence and the sniggering are pretty sure indications of taboo. And yet, with rising life expectancies, women today are expected to spend up to 40% of their lives in menopause. So imagine that. That's a huge amount of time. Now, I think we all know that menopause represents the permanent cessation of ovarian function, and it really begins after a woman has undergone 12 months without a menstrual cycle. But why should we as cardiologists care about menopause? Well, as it turns out, menopause is also a time of accelerating cardiovascular disease risk. Up until menopause, cardiovascular disease risk in women really lags significantly behind that of men. And yet, epidemiologic evidence has consistently shown that cardiovascular disease incidence is really nearly twofold higher in postmenopausal women compared with premenopausal women at every age group. And yet the mechanisms through which menopause contribute to CVD risk are really not understood well. So with that context in mind, here is our roadmap for today's talk. I'll first talk about menopause as a time of accelerating cardiovascular disease risk, what happens during menopause with respect to cardiometabolic health. Then we'll get into the nitty-gritty of the complex and very confusing history of menopausal hormone therapy and CVD risk. And finally, I want to end on thinking about how can we probe mechanisms of menopause-related cardiovascular disease with translational approaches. All right, so let's get started. The menopause transition is characterized by distinct patterns of alterations in cardiometabolic health, including adverse changes in lipid profiles, body composition, and vascular function. For example, during the menopause transition, women are known to experience adverse changes in many lipid and lipoprotein measures that have been linked to greater risk of cardiovascular disease. Displayed here are data from the Study of Women's Health Across the Nation, or SWAN study, which is a prospective study of the menopause transition in about 3,000 women. And what I think you can appreciate here is that there are substantial increases in total cholesterol, LDL cholesterol, and apolipoprotein B within the time interval between the 1 year before and 1 year after the final menstrual period. And these changes are really thought to be beyond what we would expect with chronologic aging alone. Now, the relationship between menopause and HDL cholesterol is a little bit more complicated. What the SWAN investigators have found is that HDL cholesterol may not be as atheroprotective following menopause as it is before menopause. So we certainly see a slight decline in HDL cholesterol after the final menstrual period. But I think what's more interesting is that there does seem to be an apparent reversal in the direction of association between HDL cholesterol with cardiovascular disease risk following menopause, with higher levels of HDL associated with less carotid atherosclerosis before menopause, but greater carotid atherosclerosis after menopause. Now, what the SWAN investigators found is that it looks like HDL function as measured by HDL cholesterol efflux capacity per particle actually declines during the menopause transition. So essentially, HDL particles become less efficient at promoting cholesterol efflux following this important life transition. And this may explain why HDL cholesterol is actually associated with greater progression of atherosclerosis following the menopause transition, and may explain why we see an acceleration in cardiovascular disease risk among postmenopausal women. So what about weight gain? Well, many of my midlife women patients, and I'm sure yours too, are constantly coming up to me saying, well, I put on a lot of weight after menopause. Could this all be related to menopause? Well, as it turns out, midlife weight gain is actually largely explained by changes in chronologic aging. So this was a really interesting study that looked at two groups of midlife women from the SWAN study and another study called the Healthy Women Study. And investigators actually looked at changes in weight across a 3-year period among women. And what they found was that on average, women gain about 2 to 2.3 kilograms during the midlife, but that there weren't any appreciable differences in weight gain by menopause status. What they did find, however, is that body composition changes quite a bit during menopause. What we see is that menopause actually leads to an increase in total body fat, especially visceral adipose tissue, and a decline in lean mass. So these are data, again, from the SWAN study, where investigators actually used DEXA scans to measure body composition. And what you see is that in the 2 years before the final menstrual period, up to 2 years after the final menstrual period, fat mass actually doubled while lean mass declined significantly. And these changes are really notable because we know that visceral adipose tissue, for example, is known to be associated with greater cardiovascular disease risk. And what was really interesting is that these menopause-related changes in adipose composition were actually shown to be associated with measures of subclinical cardiovascular disease. So in this study, what they saw was that the trajectories of a subclinical cardiovascular disease as measured by carotid intima media thickness actually mirrored the trajectory of visceral adipose tissue. So before 2 years prior to the final menstrual period, you saw that there was no change in carotid IMT, followed by an accelerated increase in carotid IMT in the perimenopause period, and then finally a slower increase in carotid IMT after the final menstrual period. And finally, the other really interesting observation is that menopause also seems to be associated with greater accumulation of cardiac fat. And this is also extremely important, as we know that cardiac fat has been associated with heightened risk of cardiovascular disease. So these are data from about 450 women from the cardiovascular fat ancillary study of the SWAN study. And what the investigators found is that among late peri and postmenopausal women, those women had about 10% greater epicardial adipose tissue, 20% greater pericardial adipose tissue, and 12% greater total adipose tissue compared with pre and early perimenopausal women. And these observations really persisted even after adjusting for age, BMI, and other relevant covariates. So what do we know? So taken together, what we know is that menopause is largely weight neutral, but we do see a dramatic change in body composition with greater total body fat, including visceral adipose tissue and cardiac fat. and that these changes in body composition actually mirror trajectories of subclinical cardiovascular disease. All right, so we've talked about lipids, we've talked about body fat and overall body composition. What do we know about vascular function and blood pressure? Well, we do know that the menopause transition is associated with adverse changes in vascular function. Specifically, vascular function is measured by endothelial dysfunction, and arterial stiffness really does appear to decline during the menopause transition. This figure here actually displays data from about 130 healthy women who underwent endothelial function measurement with brachial artery flow mediated dilation. And what you can see is that there's a stepwise decline in brachial artery FMD over the menopause transition, but a slight acceleration in decline between the early and late perimenopausal periods. And then the right-hand panel displays data from about 339 women from the SWAN study that shows you that arterial stiffness as measured by carotid artery pulse wave velocity actually rises appreciably during the menopause transition, particularly among Black women. Now, do these changes in vascular function actually translate to differences in blood pressure and hypertension? Well, the answer is we don't know. The data on the relationship between menopause and blood pressure are conflicting. There have been many studies that have looked at this exact relationship, and some have shown that menopause is in fact associated with an acceleration in prevalence of hypertension, while others have shown that there is no relationship between menopause and hypertension. And interestingly, one group hypothesized that maybe women don't actually all share the same blood pressure trajectory over the menopause transition, and that perhaps this heterogeneity explains why the data are so conflicting on menopause and hypertension. So this is a study of about 3,300 women from the SWAN study. They actually had 28 years of follow-up data across the final menstrual period. Median follow-up was about 19 years. And what the investigators discovered is that they could bin women into 3 blood pressure trajectories across the menopause transition. The first group that they called the low accelerated rise experienced a slight increase in systolic blood pressure, pulse pressure, and mean arterial pressure before the final menstrual period, followed by an accelerated rise in those blood pressure metrics following the final menstrual period. The second group, called medium linear rise, showed a monotonic increase in blood pressure through the menopause transition. And finally, the last group that they called the high slow decline group experienced slight increase in systolic and diastolic blood pressure before the final menstrual period, followed by an actual decline in those blood pressure measurements following menopause. Now, are there any predictors that can help us identify which women belong to which blood pressure group? Well, a key surprising finding from this study is that women with low baseline cardiovascular disease risk were actually more likely to experience an accelerated rise in blood pressure over menopause. So they were more likely to belong in that first group, the low accelerated rise group. By contrast, women with moderate to even high cardiovascular disease risk at baseline actually did not see that same acceleration in blood pressure after menopause, and some even experienced a decline in blood pressure following the menopause transition. So I think what those data highlight to us is the importance of serial blood pressure measurements across the menopause transition and during the midlife, particularly among women who we might traditionally consider to be low risk by cardiovascular risk profile. Ultimately, we still know very, very little about the relationship between menopause, hypertension, and blood pressure. But I think this study really challenges us to rethink the prevailing notion that maybe all women are created equal with respect to ovarian influence on blood pressure risk. And really, I think, highlights the need for us to tailor our preventive and therapeutic strategies to each woman's unique blood pressure journeys. Okay, so I think we've now, set the stage, discussed the adverse changes that we see that occur with respect to cardiometabolic health as women traverse this important life transition. Now, let's move on to discussing sort of the swinging pendulum of menopausal hormone therapy and CVD risk. And before we do that, though, I just want to do a quick review on the cardiac effects of estrogen. Estrogen is actually known to regulate a number of biological processes that are important to the development of cardiovascular disease. Specifically, estrogen reduces oxidative stress, endothelial dysfunction, and inflammation. It inhibits the activation of the renin-angiotensin-aldosterone system, increases natriuretic peptide production, and attenuates fibrosis. And loss of inhibition of these biological processes is really thought to contribute to the acceleration of cardiovascular disease risk that we see following menopause. And this is really why, for many, many years, absence of ovarian estrogen was hypothesized to explain the many adverse changes in cardiometabolic health that we just reviewed, as well as the acceleration of cardiovascular events that we see following menopause. And this was really bolstered by observational data that demonstrated a significant association between postmenopausal estrogen therapy use with major coronary disease and fatal cardiovascular disease. But as many in this room and online will remember, the landmark WHI and HERS trials found that hormone therapy for the primary and secondary prevention of cardiovascular disease did not reduce cardiovascular events. And in fact, in the WHI, hormone therapy paradoxically increased cardiovascular events, specifically stroke and venous thromboembolism. These findings really effectively refuted the prevailing hypothesis at the time that decline in estrogen was the leading driver of the acceleration of cardiovascular events that we see among postmenopausal women. So it turns out that the story is a little bit more complex, as with most things in medicine, and that the adverse effects or the cardiovascular effects of hormone therapy seem to be influenced by when hormone therapy was initiated. So what the WHI investigators did is they went back, they looked at their data now, and with age stratified analyses with longer cumulative follow-up time, what they found was that the absolute risks of adverse events after hormone therapy initiation were much lower for younger women under age 60 who initiated hormone therapy within a decade of menopause. And this has been substantiated by a systematic review from the Cochrane review that demonstrated that hormone therapy actually reduced coronary heart disease by half and by reduced all-cause mortality by 30% among women who were less than 60 years of age and less than 10 years after menopause. By contrast, there was no effect of hormone therapy on coronary heart disease or all-cause death among women, older women who were further out from menopause. So based on those data, 2 randomized trials tested this so-called timing hypothesis by examining the effect of menopausal hormone therapy on subclinical cardiovascular disease as measured by carotid intima media thickness among younger postmenopausal women. So the KEEPS trial included women who were within 3 years of menopause only, and what they found was that there was no increase in carotid IMT progression with the use of low-dose oral or patch estrogen. And then the ELITE trial actually found a reduction in the progression of carotid IMT with menopausal hormone therapy use among women who were less than 6 years post-menopause, but no effect among women who were greater than 10 years post-menopause. So right about now, you're probably scratching your head saying, well, where does this leave us? This is so complicated. And to really answer this question, I think it's actually helpful to review how we got here. So menopausal hormone therapy use actually began in the Great Depression when Premarin emerged on the market for the treatment of menopause-related vasomotor symptoms. But enthusiasm actually waned by the 1970s when scientists discovered the link between unopposed estrogen use and endometrial cancer risk. Fortunately, very quickly after it was discovered that by adding progestogen to estrogen, you could actually reduce endometrial cancer risk. And in the 1990s, with observational data like from the Nurses' Health Study that showed an association of estrogen therapy use with lower risks of cardiovascular disease, this really fueled a dramatic increase in use of menopausal hormone therapy. And by the mid-1990s, over 90 million prescriptions of hormone therapy were being given per year in the United States alone. Now, cracks in the armor began to show in the late 1990s with the publication of the HERS trial, which demonstrated no significant decline in cardiovascular events for the secondary prevention of cardiovascular disease. But I think as we all remember, the final nail in the coffin really occurred in 2002 with the publication of the WHI trial. And hormone therapy prescriptions plummeted following that publication of the WHI. And even after the KEEPS and ELITE trials, hormone therapy today is really only prescribed to about 3 to 4% of peri and recently postmenopausal women, which translates to about 10 to 15 million prescriptions per year. So what does menopausal hormone therapy look like in 2025? Well, menopausal hormone therapy, also colloquially referred to as hormone replacement therapy or HRT, is treatment that's targeted at the relief of menopause-related symptoms and not for the prevention of cardiovascular disease. There are currently 4 FDA-approved indications, and they're listed here, and they include prevention of vasomotor symptoms, osteoporosis prevention, premature hypoestrogenism, and vulvovaginal atrophy. And menopausal hormone therapy usually consists of either estrogen alone for women who do not have a uterus, or estrogen in combination with a progestogen for women who do have an intact uterus. And there are currently 3 formulations: oral, transdermal, and vaginal. Oral and transdermal are considered systemic hormone therapy with really similar efficacy, but transdermal is thought to have a better or safer cardiometabolic profile. And then vaginal estrogen is minimally absorbed and primarily used for the treatment of vulvovaginal atrophy. Although importantly, there is a femring vaginal ring on the market that does deliver systemic doses of hormones. Now, I just mentioned that we think that transdermal hormone therapy is safer than oral hormone therapy. And is that true? Is it truly safer? This really comes from the concept that oral estrogens undergo first-pass hepatic metabolism, which is known to increase coagulation factors, triglycerides, and inflammatory markers. And there are some data that seem to substantiate this theory, although the data are really quite variable in terms of quality. The best data we have come from really looking at lipids. There are 11 randomized controlled trials that have looked at oral systemic hormone therapy versus transdermal on lipid outcomes. And what we found is that while transdermal hormone therapy is largely neutral in terms of triglycerides, oral hormone therapy does lead to increase in triglyceride levels. Now, data looking at venous thromboembolism and MI outcomes are much more scant, and the quality is much more limited. For venous thromboembolism, there have been no randomized control trials that have specifically looked at this question of oral versus transdermal. But in observational studies, it does seem that consistently transdermal hormone therapy seems to be associated with lower rates of venous thromboembolism compared with oral therapy. And in terms of MI outcomes, there really have been no studies designed to compare the difference between systemic versus transdermal formulations of hormone therapy. So taken together, not great data, but overall the expert consensus feeling is that the cardiometabolic profile of transdermal formulations do seem to be better than oral formulations, and that's really how we think about guiding our patients. So an important role for the cardiologist in this space is to help guide who we think should be initiated on hormone therapy and to really assess the cardiovascular safety of menopausal hormone therapy among individuals who meet one of the 4 FDA-approved indications. And the way we do that is by actually looking at 2 things. We look at 10-year ASCVD risk and then years since menopause onset. So if you have a patient who has low ASCVD risk and is less than 10 years postmenopause, we actually think that menopausal hormone therapy is totally safe, either oral or transdermal. Now, if your patient has an intermediate ASCVD risk, but again, also less than 10 years since menopause, we do again think that hormone therapy is safe, but this is where we do recommend the transdermal formulation for the favorable cardiometabolic profile. Now, for women who are low or intermediate ASCVD risk, who are greater than or equal to 10 years post-menopause, this is when we start to say, we should really be thinking about alternatives and avoiding systemic hormone therapy if at all possible. But for patients who have very severe vasomotor symptoms, this is an opportunity to have a shared decision-making discussion about what is really the right therapy for your patient. And then finally, for patients who have high ASCVD risk, we really do recommend avoiding menopausal hormone therapy. Now, what about the role of coronary artery calcium scoring? I get this question all the time. And I know we're all well aware that we use CAC to really help risk stratify intermediate risk individuals and to really help tailor preventive strategies like statin therapies. Now, there are no data looking at CAC scoring with respect to menopausal hormone therapy initiation, but expert consensus has really sort of extrapolated that framework to the initiation of menopausal hormone therapy. So for women who are intermediate risk, who have intermediate risk for cardiovascular disease and have a CAC score that's 0, we say, okay, hormone therapy is totally reasonable. We would again recommend the transdermal formulation. If their CAC comes back 1 to 99, this is where I recommend starting a lipid-lowering medication, but you can also start these patients on transdermal hormone therapy. Now, if their score is greater than 100, this is where you should have a little bit more caution. This is when I would prescribe aspirin, lipid-lowering medication, try to get their target LDL to less than 70 before I actually initiate transdermal menopausal hormone therapy. And finally, for women who we discover have a CAC of greater than 300, which we really think to be equivalent to a clinical ASCVD, we really do, again, recommend avoiding menopausal hormone therapy. Okay, so now you've assessed your patient and you have determined that actually hormone therapy is not safe for your patient. Now what? Are there other non-hormonal alternatives for these patients? And the answer is yes. There have actually been a number of studies that have looked at the efficacy of non-hormonal alternatives for improving vasomotor symptoms. And all of these alternatives have been shown to be effective in reducing menopause-related vasomotor symptoms, albeit not as effectively as systemic hormone therapy. And these things include things like lifestyle measures, antidepressants, including SSRIs and SNRIs, gabapentin, oxybutynin, and clonidine. And finally, excitingly, there is a new kid on the block, fezolinetant, which is a novel neurokinin 3 receptor antagonist that actually works to reduce vasomotor symptoms by acting at the hypothalamic thermoregulatory center. And it was actually FDA approved in 2023 for the treatment of moderate to severe vasomotor symptoms or hot flashes related to menopause. And in phase 3 trials, fezolinetant actually reduced the frequency of severity of vasomotor symptoms by over 50%. And the onset of effect was quite fast. They saw effect at even 1 week of treatment with peak effect at 4 weeks, with sustained benefit all the way out to 52 weeks with continued use. And now there's actually a newer agent. It's a combined neurokinin 1, neurokinin 3 receptor antagonist named elinzanetant that also has been shown to be effective at reducing frequency and severity of vasomotor symptoms in women with moderate to severe VMS. And the company is hoping to seek FDA approval, hopefully as early as this summer. Okay, so for the final part of my talk, I really wanted to think getting to the heart of the matter. This question of menopause-related cardiovascular disease has been really one of the central questions of women's health for the past many, many decades, and we've really made very little progress in trying to understand the mechanisms. And so I'd like to explore how we might be able to probe mechanisms with translational approaches. Our research group is really interested in trying to understand mechanisms underlying menopause-related cardiovascular disease. And specifically, we're interested in trying to identify biological pathways that are orthogonal to estrogen deficiency. And so we did this by comparing 71 cardiovascular disease protein biomarkers in pre- and postmenopausal women from the Framingham Heart Study. And we displayed our results in this heat map where biomarkers that are higher in women are shown in red, and those biomarkers that are higher in men, our referent group, are shown in blue. So if we look at this first row, this is actually just comparing differences in cardiovascular disease protein biomarker levels between all women and men. And what we found was that some biomarkers, including markers of inflammation and obesity-related pathways, were in fact upregulated in women, while other markers, including platelet homeostasis and fibrosis markers, were actually higher in men. Next, we compared biomarker profiles of premenopausal women with men. And what you can see here is if you compare rows 2 to 1, there's some differences, but overall the red areas are still red, and the blue areas are still blue. Now, what happens with biomarker profiles with the onset of menopause? Well, what we found was that the cardiovascular disease protein biomarker profile of postmenopausal women appears to be more similar to men. Now, the female enriched biomarkers, those shown in red here, are still higher in postmenopausal women compared with men. And these are the markers of inflammation and obesity-related pathways. But differences between the male enriched biomarkers, those that were previously shown in blue, are now attenuated. And then perhaps what's most interesting is that administering hormone therapy appeared to rescue the premenopausal biomarker phenotype. So women, postmenopausal women on hormone therapy, their biomarker profiles no longer looked like men, but more similar to premenopausal women. So taken together, I think what these findings tell us is that menopause and hormone status influence some, but not all circulating levels of cardiovascular disease protein biomarkers. And I think that really makes sense, right? We've all been so focused on this question of estrogen. Well, estrogen is only part of the equation. There are obviously other biological pathways that are being modulated during this important life transition that we haven't yet fully understood. Now, we were really interested in this observation that inflammatory biomarkers are upregulated among women in general and continue to remain upregulated among postmenopausal women compared with men. And so we tried to further understand this phenomenon using lipidomic profiling. Our research group has an ongoing effort to study a class of molecules called eicosanoid metabolites. And these are bioactive lipids that are derived from arachidonic acid that regulate the upstream initiation and suppression of systemic inflammation in humans. And what we did was we did a similar experiment like we did with the cardiovascular protein biomarkers. We looked at differences in eicosanoid metabolites between men and women, with metabolites that were higher in women shown in red, and those that were higher in men, our referent group, shown in blue. And we again see the most pronounced differences in eicosanoid metabolites between premenopausal women versus men. And again, the eicosanoid profile of postmenopausal women actually appears to be most similar to men. And finally, administering hormone therapy does seem to, again, recapitulate the premenopausal eicosanoid phenotype. So I think, again, just highlighting the complexity of the influence of menopause and hormone status on biological processes that are really important for the development of cardiovascular disease. Now, what about timing of menopause? Can timing of menopause shed light on mechanisms of menopause-related cardiovascular disease? We've just spent a lot of time talking about the acceleration of cardiovascular disease events following menopause. And this is especially true for women who actually undergo menopause at an earlier age. So the median age of menopause in this country is about 52 years of age. And women who undergo menopause early is defined as, or having early menopause is defined as having menopause before age 45, and premature menopause is before age 40. And what we found is that women with a history of early or premature menopause are actually at risk, or greater risk, for developing cardiovascular disease later in life. These are data from pooled data from 15 observational studies that comprise over 300,000 women that examined the association of age at natural menopause with incident cardiovascular disease. And I think you can appreciate that the risk of developing cardiovascular disease actually increases with every year decline in age at natural menopause. So we really wanted to, again, get at what are the pathways that underlie this increased risk of cardiovascular disease. So we used that same protein biomarker platform from the Framingham Heart Study. And this time we actually compared biomarker profiles of women who undergo early menopause compared with normal, or sort of the median age of menopause. And what we found was that biomarkers of inflammation, adiposity, and neurohormonal regulation were upregulated among women with a history of early menopause. And again, what these highlight to me is that there are, in fact, pathways orthogonal to estrogen deficiency that are operant in the pathogenesis of menopause-related cardiovascular disease. And what about hot flashes? Well, are hot flashes the link between menopause and cardiovascular disease? I think many people, when they think about menopause, they think about hot flashes because over 80% of menopausal women will actually experience hot flashes or vasomotor symptoms. And over a third will actually experience severe vasomotor symptoms. And they actually last quite a long time too. The median duration of vasomotor symptoms is 7 years. Now, I think we're all aware that hot flashes, night sweats, other vasomotor symptoms significantly impact quality of life, mood, sleep quality. But I think that there is this prevailing notion that hot flashes and other vasomotor symptoms are largely benign and have few implications on physical health. Well, as it turns out, there are a lot of emerging data that actually suggest the opposite, that vasomotor symptom burden is associated with adverse cardiovascular risk factors, including things like diabetes, hypertension, hyperlipidemia, subclinical cardiovascular disease, including endothelial dysfunction, and even incident cardiovascular disease. So I think this is an area that is ripe for future investigation and really may underlie some of the relationship between menopause and cardiovascular disease. And finally, I just want to introduce some ongoing mechanistic work that we hope will help to uncover some of the important biological pathways that can explain the greater risk of cardiovascular disease that we see among postmenopausal women. So we've launched a prospective longitudinal observational study that is examining changes in inflammatory molecular profiles through the menopause transition. And we're actually looking at 3 specific inflammatory readouts: endothelial cell gene expression profiling, inflammatory proteomic profiling, and pro versus anti-inflammatory eicosanoid metabolites. And we really hope that these findings will bring novel insights into the pathways that drive menopause-related cardiovascular disease. And we're about 75% recruited, so hopefully in the next few years, we will have some new findings to be talking about. And we're especially excited about this protocol is it leverages this really unique technique where we harvest fresh endothelial cells from humans to perform transcriptomic profiling. And this is a technique that's never been used in the menopausal population before. So hopefully in a few years, I'll have something new to present to all of you. So just to summarize, menopause is a time of accelerating cardiovascular disease risk. We reviewed the many adverse changes that occur with respect to cardiometabolic traits, including adverse changes in lipid and lipoprotein measures, body composition, and vascular function. Now, the sort of elephant in the room is the menopausal hormone therapy and the risk of cardiovascular disease. What do we know about it? Well, we know from randomized control trials that menopausal hormone therapy increased risk of cardiovascular disease in the WHI, but it turns out it seems like it's relatively safe in women who are less than 60 years of age and less than 10 years post-menopause, and even among women who do have, at least intermediate risk of cardiometabolic disease. And finally, there's so much work that we need to do to really get at the mechanisms underlying menopause-related cardiovascular disease. We have shown that menopause and hormone status influence some, but not all cardiovascular protein biomarkers and eicosanoid metabolites. And I think we're really interested in trying to better understand what pathways beyond estrogen deficiency are operant during this important life transition. And finally, I just want to end with an acknowledgement of this incredible team and of mentees, mentors, collaborators that I get to work with every day. I mean, this is a dream come true, doing great science with great individuals, as well as my clinical partners at our Women's Heart Health program. And I know Emory has a very esteemed Women's Heart Health program, and it's been such a special opportunity to get to really work with such a collaborative, multidisciplinary team. And on that note, I look forward to the questions and discussion. Thank you so much.
Thank you, Dr. Lau. That was fantastic. And you brought up some really nice points. I'll start off with questions while there's some people who may be entering questions in the
Yep, I
chat
see a
as
few.
well. Do you see a few there?
I see one, yeah.
Okay, great. I'll start off with one. I was curious about the analysis that you showed, that study that stratified patients by hypertension groups, the
Mm.
three hypertension.
Yeah.
And, the conclusion was that the low baseline risk group didn't really show accelerated hypertension. But I'm just wondering, in calculating that low baseline risk, hypertension is a powerful predictor of risk.
Yes.
And I didn't see that in the list. I saw the lipid and the weight. So I'm just curious because if you start off hypertensive at a younger age, then, that's already a higher risk group. Was that accounted for in
Yeah,
that?
so that's a great point. Let me just go back to those slides that we were referring to. So it's the analysis, the key findings were really about the different trajectories. And this was the key finding here, that they were actually able to separate women out into three distinct trajectories. But then and certainly not in any adjusted analyses, they looked at just the baseline the clinical characteristics of each of these groups. And of course, this sort of low accelerated rise group, which was also the group that had the lowest cardiometabolic risk profile, they're the ones with the lowest blood pressures at baseline. And then the medium linear rise had sort of moderate levels, and then this high slow decline had the highest levels of blood pressure. So I think that's an important confounder in all of their data. But I do think that it was sort of interesting to see that the other cardiometabolic profiles like BMI, diabetes, LDL cholesterol, smoking seem to be concomitantly lower in this group. And I think what's important about it is that, do you see, like, this is the group that seems to experience this accelerated rise. And it may be, as you say, the absolute risks of cardiovascular disease may still be higher in these groups here because they're already starting off at higher blood pressure levels. They also have greater cardiometabolic risk profiles. But what they're not seeing is this acceleration in blood pressure risk during this time. I think what the authors hope to underscore is, first, women may not all be created equally. But second, don't forget about the women who, at the beginning of midlife have low cardiometabolic burden, because in fact, their blood pressure trajectories can start to catch up to other women. So, but these are still very exploratory studies, and it's really one of the only ones that's out there. The blood pressure question is a really tricky one. I don't think that anybody has really been able to identify or to really figure it out entirely. There's a really beautiful analysis that actually Susan Chang did out from Cedars-Sinai that actually suggests that all along we've been thinking, well, men and women are on the same blood pressure trajectory, and we sort of presume that after menopause we see this acceleration. But what she showed with longitudinal data is that women might start off with lower blood pressures or absolute blood pressures, but their slopes are actually steeper throughout their entire lives. So I think there's still a lot that we don't understand about sex-specific blood pressure trajectories, but obviously a huge area of need, since hypertension being one of the most significant modifiable cardiovascular risk factors. So let's see here. The first question I have online is, what about women with premature surgical menopause? This great question. Certainly the association of premature menopause with incident cardiovascular disease is true for women who both have natural and surgical menopause. And there have been some suggestion in exploratory or sort of secondary analyses that perhaps this association is even more pronounced among women who underwent premature menopause due to surgical reasons. So I think that's an important question, and has now actually been codified in our clinical guidelines that that highlight premature menopause, both natural and surgical, as risk-enhancing factors for the development of atherosclerotic cardiovascular disease. The next question I have here is, does a high polygenic risk amplify the postmenopausal risk of CVD, or is this a relatively linear association pre and post menopause? Does this increased risk similarly occur before and after menopause? Great question. To my knowledge, I don't think anybody has looked at this question, but I think it's a really important one. I think those are the questions that I see online so far.
Emily, that was such a great talk. Thank you so
you.
much. I had a question question, and it relates to compound hormone
Mm.
replacement therapy. And, we're seeing an increase in the use of compound medications outside of the world of GLP-1 RAs. And I don't know if you're seeing this in Boston too, but I have patients who are coming to see me in clinic who they are seeing homeopathic doctors who are putting them on compound HRT. How do we advise our patients about the cardiovascular risk for these type of medications when there really isn't as much data?
Oh, such an important point, such an important point. I think this actually highlights a systematic issue that we are not meeting the needs of our midlife women patients. That in Boston, we have a menopause clinic and the wait time is over 2 years and they actually had to stop seeing new patients. And yet these women are not, they're still suffering. They're having significant vasomotor symptoms. And so there's a huge cottage industry that has been really, I would even, wager to say exploiting the need of these patients. And they are prescribing things like compound hormone therapy, pellets that go under the skin that have not been FDA regulated. We do not know the safety of these compounds. And so in general, I try very hard to articulate to patients that absolutely, your vasomotor symptoms are significant. They should be treated, especially if your risk profile suggests that hormone therapy is safe and not contraindicated, and that we should do this in an evidence-based way. But I really think it highlights how little we know about menopause in general. I think, menopause training, I even read this study in obstetrician gynecologists, so OBGYNs who are thinking about this all the time, that they get like 1 or 2 sessions total in their entire medical training about menopause. So imagine primary care doctors, certainly us as cardiologists, we're getting almost nothing. And yet every woman will go through the menopause transition, right? And I just, as I highlighted, 80% of women actually experience vasomotor symptoms. A third of them will have such severe symptoms that it's impacting their daily life and activities of daily functioning. So we really, I think as a community, need to be doing a better job at being able to address the needs of our patients. And this is, especially true amongst our under-resourced communities. But yes, it's a real issue out there. Did you have a question?
Yes, thanks for the great presentation, Dr. Lau. I'm just wondering, we see those like hormone therapies seem to, like kind of help with the future cardiovascular disease. I wonder if the benefits are actually driven by estrogen, because we see in people who has PCOS, like polycystic ovarian syndrome, they're actually had a higher like estrogen state, but they seem to have increased risk of cardiovascular disease. So I'm just wondering, like, if there's anything else that's kind of, like manipulating like the outcome or.
Yeah, this is such a high, I think it really highlights how complex actually our hormonal system is, and that it made a lot of sense, when I showed those data that, okay, well, what happens in menopause? Well, women don't have estrogen anymore. So if we give them back estrogen, and certainly in preclinical models, we know that estrogen has all these great benefits on cardiovascular health. But just as you say, I mean, we obviously had the WHI results and the HERS results, and then certainly there are other populations that actually have excess levels of estrogen. How do we reconcile these sort of discrepancies? I think that's really the central question, that we don't actually understand how complex the sort of hormonal milieu, the endocrinologic system really is. And I think that's where the key is going to be, really understanding the nuances. But I think the short answer is we don't know. Like, why is it that even with the timing hypothesis, why is it that exogenous estrogen appears to be safe and maybe even potentially beneficial among younger, more recently postmenopausal women, but not in older women? We don't know what that is. There's some theories that perhaps estrogen in sort of older blood vessels may actually promote oxidative stress as opposed to reducing it. But all of these things are still very theoretical. Let's see here. Thanks, Gina. She wrote excellent review. I think that's all the questions I see here. Any other questions in the room?
Wonderful. I really enjoyed your talk.
Thank you.
As you transition to this cycle in life, the transition has to do with lots of oscillation and hormone levels. Are you able to also see individually per increases and decreases? Because pretty much like it is always looked at as a timeline and
Mhm.
decrease in hormone. But like, is it like also cut down to like those significant times of increase and all of a sudden drops,
Mhm.
decreases?
That I think you again highlight such an important question, which again highlights the complexity of all of this, right? We, women's menstrual cycles, it's cyclical, right? We don't have the same level of estrogen all the time, but when we give back hormones, and even in the perimenopausal period, right? You have very big swings in estrogen, FSH, et cetera. But when we're actually delivering hormone therapy, you're giving the same dose the whole time, and that's not physiologic at all. There are very few studies that have really looked at the cyclical nature of estrogen therapy. And in fact, one of the key limitations of sort of epidemiologic research in this space in general is that, say, for example, we measure estrogen levels among premenopausal women. When are we measuring their estrogen levels? Are we measuring it at the beginning of their menstrual cycle, when they're menstruating? The levels will be highly variable, and we're trying to make these inferences based on data that are actually highly non-specific. And so I think, obviously, I think that it creates complexity when one is conducting a research study. But for that reason, actually, in our longitudinal study, we actually have women come back on their menstrual cycles to be able to try to capture their estrogen and FSH levels sort of at the lowest point in their menstrual cycles among women who are still menstruating. But I think that's exactly one of the complexities that has made this such a difficult topic to study.
The preceding program is copyrighted by Emory University.